castrate-resistant non-metastatic state with docetaxel, where there are no randomized trials. So I'm going to be focusing on the STAMPEDE trial as well as some extrapolations of the data from CHARTED as well as JTUG. I think that also the discussion we had before when we were talking about median survivals, remember the docetaxel median survival was a 1990s number. And the context and the types of treatment are different. The patients are different. And remember, too, that that 3-month difference was in the setting of docetaxel being available to patients. About 30% on both of those trials did receive docetaxel afterwards. I think that number is a bit diluted. So we know that chemotherapy given earlier in castrate-sensitive prostate cancer makes a difference. And can we think about this in terms of the different states of disease with prostate cancer? So we really have a couple of different trials that have shown us that chemohormonal therapy improves survival. As we know, the CHARTED trial looked at patients with more than four lesions on bone scan, at least one outside the axial skeleton or visceral disease, and found that in those patients there was a 17-month overall survival benefit. We really didn't see a difference in survival for the low benefit patients, and Chris Sweeney has subsequently published that. STAMPEDE will see some data based upon different disease states in a few moments. They did not stratify the low versus the high volume disease state. And for hormone-sensitive disease, it's felt that the standard of care should be either androgen deprivation therapy plus docetaxel or abiraterone for those patients with high volume disease. I think it's a little bit less clear as to what should be done for the low volume disease. So in reviewing CHARTED, it's a randomized trial that took patients with metastatic hormone-sensitive prostate cancer. They could have had prior adjuvant androgen deprivation therapy. It was stratified by more than 12 months versus less than 12 months. And they were randomized to receive docetaxel for 6 cycles without prednisone for 75 milligrams per meter squared or standard androgen blockade. Patients were reevaluated every 3 weeks while on docetaxel. And then they were followed to progression and then overall survival. And the trial was closed early due to the fact that there was a large difference. 790 men were accrued, and the DSMB shut it at a median follow-up of 29 months. And this is the primary endpoint for all patients, about a 13-month difference in the median. The hazard ratio is 0.61. Just shut the light off. And then, as I mentioned before, this issue about the low-volume disease versus the high-volume disease, a 17-month difference in the low-volume disease. The initial look at the high-volume disease, excuse me, the initial look at the low-volume disease showed that there was no difference in median survival. And then this has subsequently been confirmed with further follow-up in a publication. I believe it came out in JCO by Chris Sweeney's group. So why? Is this a biological difference? Is this simply a stage difference? I think that there probably is something biologically different about these low disease patients, perhaps that makes them just simply more sensitive. The chemotherapy does not add anything. And I think what we really need is a good understanding of what the resistance mechanisms are. Everything was pointing in the right direction as far as the secondary endpoints were concerned. PSA normalizing, that's been shown from data from Maha Hussein to be an important prognostic factor. If you normalize your PSA at 7 months, you're going to do better than those patients who do not. And we see a clear trend in PSA normalization in favor of earlier chemotherapy. Again, median time to castration-resistant disease, 6-month difference in favor of early chemotherapy. And then clinical progression, it's actually about 12 months improvement in clinical progression for early chemotherapy versus androgen deprivation therapy alone. So this was felt to be a standard of care, 6 cycles of docetaxel plus androgen deprivation therapy for those patients who are suitable. But again, a lot of us are thinking of this in terms of only the high volume disease patients. So 2 other trials, I think, support this concept of the high volume disease. The JTUG trial looked at men with prostate cancer were treated again with androgen deprivation therapy plus docetaxel. Here was up to 10 cycles of docetaxel, and compared that to androgen deprivation therapy alone. Biochemical progression-free survival, clinical progression-free survival were improved, but when you look at the overall survival, there's no difference. And This again was attributed to the fact that there may have been more low volume disease patients in this trial. And finally, when we look at STAMPEDE, STAMPEDE is an ongoing trial that has different standards of care, and that changes over time comparing to more experimental treatments. So the trial that was presented in terms of docetaxel was broken up into several different groups. It was a trial that actually looked also at zoledronic acid as a single agent. But as we see from the M0 with docetaxel or the M0 with zoledronic acid and docetaxel, the hazard ratios are close to 1, 1.01 or 1.03. So the earlier use of chemotherapy does not impact on survival, but if you look at the progression-free survival data, there does seem to be a difference. So again, how can we explain this? Well, perhaps with further follow-up we'll see a difference, but it's indicating again that in these low-volume disease patients, that early chemotherapy is not the answer. So we don't have randomized data in castrate-resistant disease, but in the hormone-sensitive disease, there's no data that really supports the use of docetaxel in these low-volume patients. And again, you may see a delay in progression, but no survival benefit with early docetaxel. So I'll stop there.
You know, there are trials ongoing now, but when you move into the very early stages on the hormone sensitive, it just has not been a lot to write home about, Dan, on the docetaxel front. I wonder if you might comment just sort of generally about the use of docetaxel early as opposed to late, across the board, hormone sensitive, et cetera.
So, you know, I think right now it's a discussion that needs to be made with the patient. I think you have to tailor what you're going to give to the individual patient. So we generally will give abiraterone to somebody who does not want to be on chemotherapy. There's a financial cost that goes on with abiraterone as well, so chemotherapy will be favored in that particular situation. But also, abiraterone does have side effects. Liver function abnormalities, probably about 2 to 3% of patients have to discontinue it permanently, so that's an issue. Congestive heart failure is an issue as well with abiraterone and fluid retention. Docetaxel, you're 6 cycles and done. You don't have to give it continuously over 2 years. So I think you really have to tailor that to the individual patient. So I think the real more important question is, number one, what do you do when the patients progress after either abiraterone or docetaxel? I've re-challenged a couple of patients, really not seen much of a response effect, but I think we really need a larger trial to understand that, because if you think back to some of the intermittent docetaxel publications that were given years ago, where patients were treated till PSA completely went down and then recycled again once their PSAs went up, those patients were treated with a fairly, generally about 10 cycles. You're only giving 6 in the situation, the adjuvant setting. So I think that we still, I think, need a better understanding of the biology as to what these patients are doing when they progress. If they're on Zytiga, do they have ARV7? Do they have it at the same rate as those patients who fail for castration-resistant disease? These are all questions I think that we really clearly need to answer. But then, of course, the other question is triple therapy with docetaxel, androgen blockade, and abiraterone. Is that going to give you more bang for your buck? Not really clear. So I think there are a lot of questions to answer.
Is that a trial we need to do?
Absolutely.
Double, triplet?
Well, the PEACE trial, I think, is looking at that particular issue right now.
It actually goes the ADT docetaxel with the addition of abiraterone. What about the other way around, ADT abiraterone with the addition of the docetaxel? So the 2 ways to do doublets, only right. 1 way to do a triplet.
Right. So again, I think we have no data as to which way is better.
Got it.
We do know that we've published phase 1 data that you can give them safely. And then the other question is moving cabazitaxel up earlier. Is that a better option? I mean, certainly my experience with cabazitaxel, and I'm sure in your experience as well, less neuropathy, a better tolerated drug. Perhaps that may be the better drug to use in the situation, yet we have no clinical trial data that would support that. So I think we have a lot of important questions to answer in that area.
Right. All right, Dan, with that, we're going to keep moving on. So trying to keep us on